Good morning, everybody. Welcome to our ground rounds today, and I think we have an exciting agenda with good learning opportunities. And I'd like to introduce first our moderator for the panel discussion today, who's Dr. Sherif Nagueh, who a lot of you know about, who's the director of our Echo Lab, professor of medicine with Weill Cornell, really a well-renowned, internationally claimed, well-known echocardiographer, cardiologist, and multiple awards, which I think ranging from World Congresses to American Society of Echocardiography. He's been a pioneer support for our Echo Lab and really putting our center on the map across the world. As an individual, very thoughtful. I have the privilege of doing some hemodynamic research with him, and I'm still trying to catch up with his intellect to try to figure out what he figures out in 2 seconds. It takes me about 3 hours. But it's a pleasure to have Dr. Nagueh as a part of our colleague. And he's well known and in his expertise in hypertrophic cardiomyopathy, and along with Dr. Buergler and Dr. Lawrie, we've had a very successful hypertrophic cardiomyopathy program. It's a tough disease, which we see at the end spectrum for transplant, and optimizing those patients and avoiding transplant has been really the mission of this program. And I'd like to invite Dr. Nagueh to introduce the panel and then move on with an exciting day.
Thank Dr. Bimaraj for the kind introduction and for the audience to give us the opportunity to present cases this morning. It's my pleasure to introduce Dr. John Buergler and Dr. Gerald Lawrie. You all work with them and know them very well. Dr. Buergler handles the interventional aspect of the hypertrophic cardiomyopathy program, and Dr. Lawrie handles the surgical aspect. You will see some cases that highlight decision points in terms of management. Some of the management options will pertain to issues of dynamic obstruction. Some will pertain to issues of sudden death risk. Dr. McKay is our fellow, and he will present the cases today, and we hope to have an interactive panel with you.
Okay, thank you, Dr. Nagueh. This will be a similar format to how we presented last year if you were here. Again, it's going to be a panel discussion, but we encourage audience participation and want this to be kind of an interactive talk. So initially, Dr. Buergler.
Hi, everybody. Okay, so this is show and tell. You guys might have remembered this slide before, especially for you annual Holcomb Grand Rounds goers. So who are these two people, please? Everybody raises their hands immediately. That's what I like to see. All right. Okay. Are they running for president? No, I guess not. All right. So let's go to the next slide. So Urt Sigurd was the gentleman on the left, and he did the first alcohol septal ablation in the world in 1994. And he stumbled across it through a series of very important observations. First was that when there was balloon occlusion of the LAD, there was ventricular wall motion abnormalities. Also the observation that some of these Holcomb patients have plain old vanilla coronary disease, and some of them were obstructed and felt bad, and after their myocardial infarction they felt great, which was very interesting. And then also electrophysiologists at that time were trying septal branch ablation to treat ventricular tachycardia. Go to the next slide, please. And William Spencer then, he took that information a couple years later and did the first alcohol septal ablation in the United States. And we've done a lot of cases here, both with myectomy and alcohol septal ablation here since it was introduced here at Methodist. Go to the next slide. So this was the newspaper of Bill Spencer in the front right, and then in the distance is Neil Kleiman. He's looking at his gloves, and on the left, Nasser Lakis with his hands on his hips. And so This was the first procedure in the United States in November 1996. So this is like almost our 20th year anniversary this year. So, all right, let's go to the next slide, and we have the cases, Josh.
So this will be a case-based kind of leading our discussion. So our first case is a 64-year-old female, has a known history of hypertrophic cardiomyopathy, which was diagnosed in 2009, who presents for a routine follow-up appointment in clinic. Since her last appointment approximately 1 year ago, she's now experiencing some progressive fatigue and dyspnea on exertion with NYHA class 3 symptoms, has been unable to tolerate higher doses of metoprolol in the past due to profound fatigue. This is a comparison to 1 year ago when she was last seen. At that time had class 2 symptoms, had an echocardiogram showing an LVEF greater than 70%, with a resting LV outflow tract gradient of 96 millimeters of mercury that increased to 110 millimeters of mercury with Valsalva. Her interventricular septum dimensions at that time were 2.4 centimeters with an MVO2 of 16.6. Her past medical history, other than hypertrophic cardiomyopathy, pertinent for hypertension, and a previous history of SVT that's status post-ablation. Her other pertinence, current medications include an aspirin 81 milligrams, and metoprolol succinate 50 milligrams BID. So on exam, the patient's afebrile, has a heart rate of 85 beats per minute, blood pressure 131/78, respiratory rate of 18, and is comfortable in room air. Her MVO2 at this visit is 13.6, which is 51% predicted, and down from her previous value of 16.6 1 year ago. Her physical exam is pertinent for a right-sided carotid Buergler, as well as a late peaking systolic murmur at the left sternal border that radiates to the carotids and is increased with Valsalva. So echocardiogram during this clinic visit is shown. These are the long axis views. You'll note that there's substantial increase in the interventricular septal dimension, as well as a systolic anterior motion of the anterior leaflet of the mitral valve. And the color Doppler views, you'll note that there's significant flow acceleration below the level of the aortic valve here at the left ventricular outflow tract. With continuous wave Doppler, you see the overall morphology is consistent with a dynamic outflow tract obstruction with a peak gradient of approximately 98 millimeters of mercury. Patient also underwent a cardiac MRI. Again, it shows asymmetric septal hypertrophy with systolic anterior motion of the anterior leaflet of the mitral valve and a flow acceleration at the level of the left ventricular outflow tract, highlighted here kind of in the white turbulent flow.
Do you have any comment on the papillary muscle morphology there? It's quite a large papillary muscle.
Let's go back and see if we can play again. Yes, this posterior papillary muscle does look enlarged. I'm not sure the significance unless the panel has a comment.
So papillary muscle hypertrophy is part of the HCM morphology. It's expected. More than 50% of cases of HCM, when the papillary muscle is measured, if you were to quantify its mass, certainly most suitable by cardiac MR, would have a mass that exceeds 7 grams per square meter. That's the definition of a papillary muscle hypertrophy. In and of itself, in a posteromedial location, as in this case, does not necessarily contribute to the obstruction, but an anterolateral papillary muscle that is hypertrophied, also that is displaced anteriorly, would bring the mitral apparatus closer to the septum and contribute to obstruction. Of importance, because in that setting, surgery aimed simply at myectomy may not be as effective as other approaches, and Dr. Lawrie can elaborate on that.
Yeah, it's important also to recognize that the anterior and posterior papillary muscle both sit in the posterior one half of the left ventricle, so that shadow there is probably a combination of both. You can see the anterior papillary, the anterior mitral leaflet is attached to that head. The less dense head is probably the head of the anterior papillary muscle. As Dr. Nagueh says, evaluation of the papillary muscles in the context of myectomy is very important to get a complete result.
So in summary for case 1, it's a 64-year-old female. The progressive dyspnea on exertion, currently NYHA class 3, has a worsening MVO2, which is currently 51% of predicted, has a left ventricular ejection fraction greater than 70% with an interventricular septum measuring 2.5 centimeters, has systolic anterior motion of the mitral valve with mild MR, a resting LV outflow tract gradient of 98 millimeters of mercury, and is on a maximally tolerated dose of beta blocker. So now I'll open up the panel about now what is the next best steps.
Just one comment. It is important in these patients who present with symptoms that the patients or the physician may feel it's sort of an NYHA class 2 to consider requesting an exercise MVO2 test. Not infrequently there is a discrepancy. On this slide we have the 3 and we have the MVO2 of 16.6, but they're very of the 15 of something less even than 15. On the very first presentation when it was felt that she was NYHA class 2, her MVO2 was pretty low at 16.6. So these are factors that physicians do sort of need to look at in making recommendations, be it with adjustment of medications or plans to move on with the next step.
When you say the interventricular septum is 2.5, is that at the hypertroph or is that the free wall, the lower basal
That should be at the
septum?
hypertroph. That should be the maximal dimension.
She had generalized LVH. I was just wondering if you had a measurement for the thickness of the general wall of the ventricle.
We don't have it recorded here. I could say in general there may be some element of concentric LVH with the posterior wall, but you can see here the posterior wall is not.
If you freeze at it, I don't know if the system allows you to freeze, but if you freeze at an end diastolic frame, you can best appreciate which segments are hypertrophied and which are not. The systolic, everything is sort of thick and comes in. When you freeze the diastolic, while the infralateral wall has some increased thickness at the base and mid segments where the pap muscle sort of takes off, as you go apically, there is a much thinner wall. So the pattern is still consistent with an asymmetric hypertrophy, and even though the infralateral wall is thick, the anterior septum is the thickest of all the segments that we have seen on this slice. The point of looking at the maximum wall thickness is important and would come from looking at the stacks of short axis views that cardiac MR can present. We also can look at with echocardiography, albeit with cardiac MR a better spatial resolution, and that factors in and recommendations regarding sudden cardiac death, primary prevention in terms of ICD therapy. But for this case, what we have seen so far, it looks like it's the anterior septum.
So any further comments from the panel or the audience about where to go from here in terms of a patient symptomatic, presumably on maximal tolerated medical therapy?
All right, well, let's go to the next slide then. So really, you have this patient with symptoms that are refractory to medical therapy. Remember, we have to emphasize that, we don't do procedures on people unless they've failed medical therapy for hypertrophic cardiomyopathy. There's two common procedures that we do, which are myectomy and alcohol septal ablation. Let's go to the next slide, please. So remember, next slide. Surgery is traditionally thought to be the gold standard. There's no randomized controlled trial comparing myectomy to alcohol septal ablation. If you recall, there was about 4 years ago a large randomized, not randomized, a trial between alcohol septal ablation that was not randomized with surgical myectomy, and they tried to use propensity analysis to take into account all the risk factors for both sets of patients, and actually alcohol septal ablation looked fairly favorable. But that said, there is no randomized controlled trial between the two. You don't have a definite answer for what's better. There is a concern regarding a scar formation with ablation causing arrhythmias, and so that's why, according to the guidelines, they say you should seriously consider surgery. That said, it gets complicated because more patients in the United States have undergone alcohol septal ablation in the last 15 years than the entire surgical experience with surgical myectomy, which started in the 1960s. So a lot of patients will come in with predisposition about what they actually want to do. So go to the next slide, please. So this is kind of a noisy slide, and I'm going to see if I can take you through it really quickly. It's pretty straightforward. So patients with hypertrophic cardiomyopathy also have other cardiac conditions. And so, for instance, their lipids should be treated, their diabetes should be treated, and so on, which is that first green box. And then the question is whether or not they're obstructed. And if they're not obstructed, then really the question is, do they have any symptoms? If they don't have any symptoms, you should just see them once a year. If they do have symptoms, then the discussion is whether or not their EF is normal or abnormal. If their EF is less than 50, then they would get treated like a regular heart failure patient. Conversely, if their EF is greater than 50, the mainstay of therapy for these patients is beta blockade. If for some reason beta blockade is not tolerated, verapamil is the next line therapy. And then if you continue to have problems, these patients have diastolic abnormalities, as you could consider a low-dose diuretic, but certainly not until you've given them beta blockade or verapamil. Conversely, going on the left side of the slide going down, if they are obstructed, you don't want to give them vasodilators. You don't want high-dose loop diuretics. And if they have no symptoms, then you just observe them. But then if they have symptoms, again, beta blockers or verapamil, and despite optimizing their medicines, if they have persistent symptoms, then invasive therapy is indicated, either with surgical myectomy or alcohol septal ablation. And of course, if patients that don't have, they can't have surgery because of comorbidities, alcohol ablation would be preferred. And in the very unlikely event that you can't have a surgical myectomy or an alcohol septal ablation, you could theoretically consider DDD pacing. This was done 15 years ago, 20 years ago when we had no other options, actually, 20 years ago. And in isolated patients was beneficial, but in larger numbers of patients, not so much. Next slide, please. So remember that this should be in a comprehensive center. It should be in a hypertrophic cardiomyopathy center. In our center here, we do genetic testing. We do regular MVO2s. We use echo at the time of doing our procedures. All this is very important. And so, according to the guidelines, it should only be performed by experienced operators, at least 20 procedures, or in a program with at least 50 in the context of a comprehensive HCM clinical program, and only for the treatment of eligible patients with severe refractory symptoms and LVOT obstruction. So what does that mean? That means you should have at least a 50 millimeter gradient at rest with provocation. You should have symptoms that interfere with daily life despite optimal medical therapy, and the septal thickness has to be sufficient to perform the procedure. 1.6, perhaps as low as 1.5, but remember that as the septum gets thinner, the risk of a procedure would go up. Next slide. So in comparison with the two, both of them relieve symptoms. They both improve exercise tolerance. They're both indicated. The risk of permanent pacemaker, a couple of percent for myectomy. It's not that common. Remember, with a myectomy, you tend to get a left bundle branch block, whereas with alcohol septal ablation, a right bundle. They say the risk of pacemaker, 15%. Sherif and I were talking. That number is probably a bit inflated. It's probably less than 15%. The likelihood of repeat procedures with myectomy is less than 5%. With alcohol septal ablation, they said about 12%. That's pretty close to what our experience is, 12 to 15%. AFib is, with myectomy is higher. Risk of aortic insufficiency. So I would say that we don't want to overplay that at all. The significant aortic insufficiency with myectomy is exceedingly uncommon, especially with an experienced surgeon. Usually, whatever aortic insufficiency happens related to the procedure would most likely be mild. Myectomy patients tend to be younger, whereas alcohol septal ablation patients tend to be older, have more comorbidities, and so therefore be more favoring a less invasive approach. And then the septum is very important, and then we'll get back to this first case in a moment. So if the septum gets more than 3 centimeters, the myectomy would clearly be the preferred approach. Even if the septum's in the mid to upper 2s, you give a good hard look towards myectomy, especially if the patient's a good surgical candidate. Our experience is that it doesn't increase the risk of an alcohol septal ablation, but in our experience, it decreases the probability of a permanent fix. You're more likely to have a repeat procedure or some residual symptoms. And then, of course, alcohol septal ablation in terms of patient preference has been more popular over the years, as you know. Any comments, Sherif, on that?
Just for the septal thickness, yes, extreme septal thickness, and doesn't have to be extreme, even more than 2 centimeters. It is much easier to achieve a better outcome, hemodynamic success in terms of residual gradients with surgery. also at lower septal thickness, and Dr. Lawrie can elaborate on that. Surgery offers other options, whereas alcohol septal ablation would not be considered because of the risk of ventricular septal perforation. The issue of repeat procedures for the 12% is right on the ballpark. For example, in the North American Registry of 874 patients, 112 cases, about 12.8% had repeat ablations, and 25 cases needed to go for myectomy. The pacemaker incidence is indeed lower than 15%. That comes from series where they sort of average all studies starting from the early experience. A more reasonable number to present is somewhere between 5 and 10%, and it also has its predictors.
The other issue with surgery is that it can be used on, as Sherif mentioned, this condition affects other parts of the wall of the ventricle, and you can get mid-cavity or distal cavity obliteration, and all those patterns are amenable to surgery. And of course then coexistent issues with the mitral valve, the presence of abnormal papillary muscles, need for other surgery such as coronary bypass. And then there's some discussion of efficacy. Atrial fibrillation is a very serious arrhythmia in these patients and it's been associated with sudden cardiac death. And the ability to combine a maze procedure with a 70% chance of ablation, permanent ablation of atrial fibrillation in a patient with that situation is also some advantage.
So in this particular case, the patient underwent a septal myomectomy. Despite the low event rates of complete heart block with surgical myomectomy, the patient did experience a complete heart block requiring permanent pacemaker implantation. But the patient was discharged on postoperative day number 9, was seen at 6-month follow-up in clinic, doing well clinically with improved exercise tolerance and improved symptoms. So these are the postoperative 6-month follow-up images. Note the significant reduction in the septal hypertrophy here. There's no longer any evidence of systolic anterior motion of the anterior leaf of the mitral valve. And with color Doppler, you no longer see this flow acceleration turbulence in the LVOT. It's rather laminar flow. And you'll see the gradient significantly reduced to around 13 millimeters of mercury, down from roughly 100. So, any closing statements before we move to case 2?
I think it's pretty well established that successful alcohol ablation does produce comparable relief of left ventricular outflow tract obstruction. When you get a success, it's definitely equally successful. And the most common cause of recurrence with the alcohol is simple. When we reoperate on these people, you see almost a shelf where the ablation has come up and then hasn't quite reached high enough. Typically, the first septal doesn't go quite high enough towards the aortic valve. So we just have to trim off that last bit to complete the ablation.
Quick question on pacemakers. If somebody needs one, do you empirically put an ICD in, or do you judge that based off their risk for...
That is an outstanding segue to a upcoming case. So if you don't mind, we're going to table that for a moment. It's an outstanding question. Give us but a moment, and we will go there.
Outstanding question, but we're not going to answer it.
I don't know if you have a case with that, but it will be good if you can elaborate the case scenarios where you would operate on non-outflow tract obstruction, because when we see a lot of these hypertrophic patients without obstruction, we presume the rest of the myocardium is affected, and when they're having heart failure symptoms, we're really not thinking about sending them for surgery with the distal end that is thick versus the apex that is thick. So I don't know what criteria would be necessary for us to refer patients when you have an apical thickness or a diffuse thickness which are disproportionate other location than the outflow tract.
Well, the main criteria is chest pain unresponsive to treatment. These people on MRI all have a lot of scar tissue in this hyperdynamic area. And on the LV-gram or the MRI, you can see the ventricle squeezing down and becoming ischemic. And surgery is very effective. We've had an experience here with it, and the Mayo Clinic reported a series. And the surgery for the apical and mid obstruction is pretty simple to do. We do it through a fish mouth incision in the apex. We open the apex of the heart up, and we can see the papillary muscle, and we can go up and trim around everything. And we keep checking the wall thickness, and we just keep carving it down until we get to about 1 centimeter of thickness, and then the ones we've done have had good relief of symptoms, and they show no evidence of recurrent obstruction on the postoperative studies. But it's mainly for relief of intractable chest pain.
Okay, moving on to case 2. So this is a little more of a complicated history, but an 82-year-old female has a history of mitral valve disease who presents to clinic for a second opinion. Her past history began about a year ago when she developed palpitations and shortness of breath, presented to an outside emergency room, and was found to be an atrial fibrillation with rapid ventricular response. Other workup at that time revealed moderate to severe mitral regurgitation and an LV outflow tract obstruction. She was managed medically with amiodarone and warfarin and was discharged in sinus rhythm with symptoms returning to baseline. 6 months following that admission, she again developed shortness of breath due to pulmonary edema and pleural effusions and was managed medically with diuretics as an outpatient basis until 1 week ago. She again had to present to an outside emergency room with acute shortness of breath, was treated with IV diuretics and a short hospitalization and discharged, and now presents to clinic as a follow-up second opinion as to why all this is going on. Currently, she complains of NYHA Class 2 symptoms, denies any orthopnea, P&D, or edema, and continues to have intermittent palpitations that are rather short-lived with no syncope. Past medical history is also pertinent for the hypertension, hyperlipidemia, and non-insulin-dependent diabetes. She's never been a smoker. Family history is only pertinent for coronary artery disease in her mother. Current medications are amiodarone, 200 milligrams BID, amlodipine, 2.5 milligrams BID, furosemide, 20 milligrams daily, warfarin, and atorvastatin. On physical exam, she's afebrile with a heart rate of 72, blood pressure 145 over 68, respiratory rate 20, setting 97% on room air. Her BMI is 21.5, and the rest of her exam is pertinent for 4 out of 6 holosystolic murmur at the apex that radiates to the axilla, and 3+ pedal pulses with no lower extremity edema. So the patient underwent a cardiac MRI or at the conclusion of clinic, which images are shown here. Again, note that you have a significant systolic anterior motion of the anterior mitral leaflet with some flow turbulence here at the level of the LVO outflow tract, below the level of the aortic valve. Cardiac MRI calculations showed an LVEF of 82% with an interventricular septum dimension of 1.3 centimeters. Again, SAM with dynamic obstruction, prolapse of the P2 segment, and severe mitral regurgitation with a regurgitant volume of 42 milliliters, a fraction of 45%. So the patient was scheduled to come back to clinic to discuss these results and monitor her symptoms. But prior to that appointment, she again had to present to an outside hospital emergency room for shortness of breath, required intubation for hypoxic respiratory failure, was started on diuretics for pulmonary edema, but subsequently became hypotensive, requiring phenylephrine, and was transferred to Methodist Hospital for further evaluation and management. So upon transfer, her inpatient status, she was afebrile with a heart rate of 72, blood pressure is 122 over 51 on low doses of phenylephrine, has a respiratory rate of 16, citing 100% on the ventilator with rather low oxygen requirements. She's intubated and sedated, but has no jugular venous distension, has brisk rotted upstrokes bilaterally, has a 3 out of 6 holosystolic murmur at the apex with bibasilar rails, no lower extremity edema, and adequate pulses. She subsequently underwent a right and left heart catheterization, which revealed normal coronary anatomy with no obstructive coronary artery disease. Her cardiac pressures are shown with a right atrial pressure of 5, a PA mean pressure of 29, pulmonary capillary wedge pressure of 20, with a cardiac output index of 4.1 and 2.8. Was noted to have large V waves noted on her pulmonary capillary wedge pressure tracings. So this is transesophageal echocardiogram performed at this time during inpatient stay. Again, you'll note significant systolic anterior motion of the mitral valve during systole with flow acceleration at that level. Again, you'll also notice some mild aortic regurgitation. Based on transthoracic measurements, she's found to have a peak LV outflow tract gradient. This is maybe somewhat overtraced, but around 150 millimeters of mercury. So in summary, this is an 82-year-old female. She's had recurrent hospitalizations for shortness of breath and pulmonary edema. She has an ejection fraction of 82% with a septal measurement of 1.3 centimeters. She has significant SAM with outflow tract gradient of 144 millimeters of mercury. She has P2 prolapse as well with severe mitral regurgitation and is currently intubated in renal failure and shock requiring vasopressor support. So we'll open up to the panel to discuss now what.
John, do you want to tell us what options you entertained for her?
Yeah, so in this particular patient, you know, there's problems with the mitral valve that's anatomic with the P2 segment. There's also a septum that's only 1.3 centimeters. So that's going to be hard to do an alcohol ablation on. Remember, we'd want the septum to be thicker to do an alcohol ablation. So we put alcohol ablation with double question marks. It's really not a valid option. So you're really wondering if you can operate on the patient versus do something else. Gerald, do you have any comments?
Well, obviously the first step would be to really optimize maximum medical therapy, which at some point will either lead to an improvement or a deterioration. And I think I know that what happened to this patient. So
yes, I think
so
yes. We couldn't get you in there. That's exactly right. Okay, so
but there is a point where the risk of open surgery is such that some other non-interventional or minimally interventional approach may be worth a try, and I believe that's what ended up happening here.
Right, and again, when you have somebody with this degree of LVOT obstruction, you know, that got larger and now they're in phenylephrine, they're really behaving as severe dynamic LVOT obstruction, right? And they also have a lot of MR, and so they have two separate problems, and so they end up getting both problems treated. So next slide. So the patient ultimately got a MitraClip. So Colin was nice enough to put in a MitraClip here, and this is the anatomy.
So you can see catheter coming in here, deploying the MitraClip, and this is post MitraClip. Again, you'll see during opening of the mitral valve, you see the clip in place.
Yep. And next slide, please. So the hemodynamics, as you can tell, are dramatic between the clip and then getting IV Esmol, doing two things at once. The gradient, instead of it being 140, 150 millimeters of mercury, is down to about 30 or so, and actually even less than that when we looked at it via other means. So, all right, Josh, you want to continue?
Sure. Yeah, I would say with clip alone, came down to a mitral gradient of around 30, LVOT gradient of around 30. And then with initiation of medical therapy on top of clip with Esmolol during the case, reduced to about 15 millimeters of mercury. So this patient tolerated the procedure well, was able to be weaned off vasopressors within 24 hours of the procedure, and subsequently extubated on postoperative day number 2. She was continued on management with beta blocker and diuretics to optimize her, and was discharged on postoperative day 14 to a SNF for continued rehab. This is her follow-up echocardiogram and clinic follow-up. Again, you'll note that her septum is mildly hypertrophied, but not to the level we've seen in the previous case. You'll see the MitraClip in place here, and you no longer see the systolic anterior motion of the mitral valve. Again, when you place color across, you no longer see the turbulent flow in the outflow tract. You still see mild aortic regurgitation, which is unchanged from previous. And then the post-gradient, you can see significantly reduced, somewhere in the order of around 16 to 17 millimeters of mercury here.
So before we go to case 3, what other surgical options do you have to deal with the mitral valve in cases where, say, the septal thickness is sort of borderline, but the patient is a better surgical candidate than this 82?
There are really two groups. One is when we can see an organic problem with the mitral valve, such as clear-cut Buerglers, for example, with very large prominent leaflets, or a flail or prolapsing segment, and there's a borderline hypertrophy present. In those cases, typically we will repair the mitral valve, then come off pump, and then observe to see whether there is in fact any residual contribution from the hypertrophy. And it's not an uncommon thing, actually. We do encounter this not infrequently when we put our TEE down intraoperatively. We pick up quite a few little hypertrophs. And I was interested in looking at the Cleveland Clinic data. 1/3 of their so-called IHSS experience is in the setting of associated valve surgery. So I think there's a certain amount of trimming off of previously undiagnosed lumps intraoperatively. But if there is, in fact, a contribution from the hypertrophy, we go up, open the ascending aorta, and resect the hypertrophy, and that only adds about 15 to 20 minutes to the surgery. Looking at it from the other direction, if there's no organic, obvious mitral valve disease, but there is significant SAM and significant MR, what do you do about it? And there have been a number of things proposed, including doing prophylactic Alfieri things, which is basically like the clip stitching the middle of the anterior and posterior leaflet together, various shortening procedures on the anterior leaflet, because in IHSS the anterior leaflet is frequently longer than normal. But what we've found in our experience of over 200 septal resections that we've done now, and is supported by some other experiences, if you do a very extensive septectomy that goes down well below the base of the papillary muscle, well down below the tips of the papillary muscles, you almost always get complete resolution of the mitral valve disease. So assuming you haven't left a big obstructing papillary muscle or any residual hypertrophy, the mitral valve problems almost always resolve with an extensive resection. But you do have to be sure to go down lower. And in general, the thing that inhibits less experienced surgeons from doing a complete operation is the lower you go, the further down this hole, tapering hole you go, and you have the all the chordae from the anterior mitral leaflet just below where you're cutting with your scissors. So people tend to chicken out prematurely. And the most common cause of there should be no recurrent gradients after surgery. And the most common cause is incomplete resection, and we've had to reoperate on a proportion of patients because of incomplete resection in other places.
Issues of an anomalous papillary muscle. Sometimes patients are referred to surgery, and this diagnosis has been established. Does the surgeon, as a routine, look for that before they start their planning?
Yes, it's pretty easy to see. When you look down through the aortic root and you retract the right coronary leaflet, the hypertrophy is usually sitting directly under that. And then as you look down further, you see the anterior mitral leaflet. You see the aortic side of the anterior mitral leaflet with the strut chordae running down. And as you follow them, you should be able to go all the way down to the apex in that plane. And if there's a big papillary muscle sticking forward that's obstructing that area, then that needs to be dealt with.
Okay, we'll move on to case 3. So this is a 77-year-old female, has a known history of hypertrophic cardiomyopathy, who presents to the emergency room complaining of chest pain and palpitations. She notes her symptoms have been progressive over the last week, occur mostly with exertion, and are also associated with nausea and a feeling of lightheadedness. She's currently experiencing multiple episodes per day, but has not had any syncopal events. Past medical history is pertinent for the hypertrophic cardiomyopathy as well as paroxysmal atrial fibrillation and COPD. She's a heavy smoker but quit 3 years ago. Is currently on aspirin, metoprolol tartrate 25 milligrams BID, Lasix 20 milligrams as needed with a potassium supplement daily. On exam, she's afebrile, has a heart rate of 60, blood pressure 132/60, respiratory rate 16, citing 100% on room air. She has no JVD, has a 2 out of 6 late peaking systolic murmur that's increased with Valsalva, has no lower extremity edema with 1+ pedal pulses. Echocardiogram at that time shown. Again, you'll notice the significant septal hypertrophy with systolic anterior motion of the mitral valve, and again, flow acceleration in the left ventricular outflow tract. Kind of a different view of the cardiac MRI, but showing similar with septal hypertrophy, systolic anterior motion of the mitral valve, and some flow acceleration.
Can we go back to the echo for a second?
Sure.
In older people, how do you differentiate between sigmoid septum versus a hypertrophy? At what point do you basically suspect a hypertrophy rather than a sigmoid septum?
So increased septal thickness. The mere presence of a sigmoid septum, which means a septum with a convexity towards the LV cavity, in and of itself does not diagnose hypertrophy and hypertrophic cardiomyopathy. Having said that, older individuals with a sigmoid septum and a smaller ventricle hyperdynamic, say in the setting of anemia, can have dynamic obstruction. Important to distinguish from HCM because the treatments are very different. The determining factor here is the septal thickness.
So other pertinent clinical information, she underwent a regadenoson stress test, which showed 0% scar and 0% ischemia. On telemetry during her hospital stay, she's noted to have multiple episodes of non-sustained ventricular tachycardia. So kind of in summary, it's a 77-year-old female, progressive exertional chest pain and palpitations. She has a negative stress test. She has a normal ejection fraction with interventricular septum of 2.3 centimeters in SAM, has an outflow tract gradient of at least 50 millimeters of mercury, non-sustained VT on tele, has a scar burden by late gadolinium enhancement on cardiac MRI of 8%. So now what?
Has she had a trial of medical therapy yet?
So she is on a low dose of metoprolol, tartrate 25 milligrams BID, which previously had her symptoms under control.
I think the cutoff for LGE as a risk factor is 15%, isn't it?
Yeah, go ahead, Sherif.
There is really no sort of recognition of a fixed number in terms of scar burden by LGE. Some people believe that it is of particular value in individuals believed to be at lower risk for sudden cardiac death. One can argue she is 77 years old, has that much hypertrophy, hasn't had any events so far. So I'm not sure of how to sort of just pick on this finding by the cardiac MR and sort of moving to say, is she a person I would recommend for a primary prevention of sudden cardiac death, talking about an ICD, or just deal with her symptoms of angina, try to maximize her medications and make a decision of what to do the next if her symptoms do not improve and she is left with a residual gradient. The decision could be individualized with each patient. Some patients, even younger individuals, may not be very sort of accepting to a recommendation for an ICD. Some older individuals may, but it's sort of a mutual decision. We typically look for major risk factors. Dr. Buergler will get into that on one of the slides. And it's not sort of a sum of these risk factors. If you have a number of risk factors, the decision is straightforward, but one individual risk factor could be enough to trigger a recommendation for an ICD.
Any family history of sudden death? Or?
There's no family history of sudden cardiac death.
And it is the case, isn't it, that the elderly tend to have a lower incidence of sudden death?
Yes, and she's made it to 77, so one can argue just based on that, the likelihood that she would experience an event is quite low. And the group of individuals where the ICD is likely to make a bigger impact on their survival are also younger individuals based on their life expectancy. Yes?
Would you use genetic studies to decide, because some gene mutations, I think, are at higher risk of...
So earlier studies from sort of groups of families with certain mutations, for example, some mutations in myosin heavy chain, were reported beta-myosin heavy chain to be more likely associated with sudden cardiac death. But then if you go to an unselected group of individuals diagnosed with this disease, not necessarily family members, the presence of these very same mutations were not associated with a higher risk of sudden death. So the presence of, or knowing what genetic mutation is present, could be looked at as a very minor factor, but in and of itself, again, would not make us weigh. John will sort of put its role in the algorithm that he will show shortly.
Next slide, please. Oh, sorry, Mawash, yes.
The question I had was this patient had concentric kind of hypertrophy. So in patients, when you see that, in which patients do you consider doing a biopsy to make sure that this is not something else?
Not sure whether this hypertrophy was indeed concentric or not. There should be sort of more data readily available from the cardiac MR as well as from the echocardiogram. But yes, a differential should be entertained. What other alternatives? Other alternative conditions, the biggest of which is the two biggest of which that you would likely to encounter clinically are hypertension and aortic stenosis. If both of these conditions do not appear to account for the severity of hypertrophy, then one can move on to the diagnosis of hypertrophic cardiomyopathy. Example, a patient with hypertension and very good control, or somebody with mild aortic stenosis. On the other hand, uncontrolled hypertension, significant degree of aortic stenosis would be enough to say this patient does not necessarily have HCM. Younger individuals, you have to look at metabolic disorders as Anderson-Fabry disease. Also cases of cardiac amyloid. I'm aware of one case here in this center that was referred with a diagnosis of hypertrophic cardiomyopathy and turned out to be cardiac amyloid. I would say the likelihood of dynamic obstruction with cardiac amyloid is very much less than what you would see with hypertrophic cardiomyopathy. And also for the metabolic disorders in general, the likelihood of having dynamic obstruction is much less.
And in this particular patient, they did have an MRI with an 8% scar, but there was no suspicion really, even though there was hypertrophy in all the walls, it was truly asymmetrical, and there was no sign of any other type of infiltrative disease or anything else on the MRI. So, initially it was thought that you needed 2 or more of the traditional risk factors perhaps to require an ICD, but that has changed based on registry data, which showed that there was very little difference if you had 1 or more of the risk factors I'm going to discuss versus 2. And, it was sort of obvious the way that happened, right? So, for instance, if somebody showed up in your office and their brother had just died suddenly, and they have the same disease, and they truly do have hypertrophic cardiomyopathy, it was very hard in the early days to say, well, you really need to have 2 risk factors. The fact your brother died last week really is not enough. We feel like probably you're okay. That didn't fly just in clinical practice, and so people were receiving ICDs for 1 clinical risk factor, and these are the guidelines from 2011, which have not changed. So obviously, if you're talking about secondary prevention, where you've had a prior cardiac arrest or sustained VT, you would definitely get an ICD, and that's a Class 1 recommendation. All the other ICDs are going to be Class 2 recommendations. So if you have a family history of sudden death, wall thickness greater than 3 centimeters, or unexplained syncope, meaning you are sitting there at rest under normal conditions and suddenly pass out, well, then an ICD would clearly be reasonable. If you have non-sustained VTAC and a Holter, which is what this patient had, or a hypotensive response to exercise, then you look for these other sudden cardiac death risk modifiers, which we already alluded to a few minutes ago. So go to the next slide, please. And these are the ones we did talk about: late gadolinium enhancement on CMR. Again, this was not consistent, but it was associated with non-sustained VT and ectopy, but not necessarily sudden death. There wasn't really a consensus on the protocol for exactly how much scar you needed. It wasn't necessarily clear that there was a linear relationship consistently where more scar is clearly associated with more, although some studies did say that. LV apical aneurysm happens about 2% of HCM patients associated with heart failure and sudden death. We talked about the genetic mutations, about it being inconsistent with families. But when you looked at the genetic mutation itself, not so much. And then LVOT obstruction, some studies have shown this to be a predictor, while others have not. And it was complicated by the fact that it's a dynamic obstruction, will vary day to day. Keep in mind that the only proven therapy to improve mortality in patients with hypertrophic cardiomyopathy actually is a defibrillator. And it does get complicated, and it is an individual decision, like Sherif said. Perhaps younger people might have more inappropriate ICD discharges. And you're statistically more likely to get an inappropriate ICD discharge than an appropriate one during your lifetime. Conversely, when you look at how many patients you need to treat, it is a reasonable therapy. So, all right. So in this particular patient, she had late gadolinium enhancement on the MRI, and then she also had non-sustained VTAC, and so that's why she got her ICD. Okay, Josh. Oh,
Sherif. To answer Dr. Parker's question about when you consider a permanent pacemaker versus a permanent pacemaker with ICD.
Yes, thank you. So, thank you very much there, Sherif. So, obviously, in those patients in whom these things qualify in and of themselves, based on the prior slide, they would get an ICD in. In whom they do not qualify, we do not routinely put in pacemakers to improve symptoms. Incredibly rare in 2016, where a patient could not get a surgical myectomy or an alcohol septal ablation and then just gets a DDD pacemaker for symptoms. That said, there is an incidence with alcohol septal ablation where it's about 10% where they require the pacemaker after the alcohol septal ablation, approximately 2% for surgical myectomy where they would get a pacemaker.
So in other words, if the case is, say, needing a permanent pacemaker after an alcohol ablation, that would be a reasonable recommendation. Let's put an ICD permanent pacemaker in her if she's going to need a permanent pacemaker anyway.
Yeah, so in the past, unless they had one of those risk factors, right, that we showed, we have not here at Methodist said, okay, you're going to get a defibrillator even though you need a pacemaker de novo. What we'll often do is we will set them up for a permanent pacemaker if they have none of these criteria, and let's say they're young. It's always possible several years down the road things may change and we'll reevaluate. And so they may get an ICD lead, but they'll be hooked up as a permanent pacemaker, and then if and when at some point they'll have signs of a hypotensive response to exercise, a family member dies suddenly, one of the risk factors comes up, well then it's very easy to convert to an ICD.
So fast forwarding on this patient, she was discharged from the hospital feeling better, but later presents back to the emergency room complaining of recurrent chest pain and palpitations, again mostly with exertion, daily episodes, no syncope, no ICD shocks. ICD interrogation revealed only short runs of non-sustained ventricular tachycardia that were seen previously, and she's been unable to tolerate the higher doses of beta blocker that she was discharged on due to fatigue. So again, in summary, recurrent exertional chest pain and palpitations, negative stress test, has an interventricular septum of 2.3 centimeters with SAM, an outflow tract gradient at least 50 millimeters of mercury, has non-sustained VT, status post pacemaker and ICD, and is on maximally tolerated dose of beta blocker. So any further therapies we can offer her.
Yes, okay, let's go to the next slide, please. So go ahead, Josh.
So in the interest of time, so she underwent a septal myomectomy at this time, again, for refractory symptoms despite optimal and maximal tolerated medical therapy. She tolerated the procedure well, was left with no residual outflow tract gradient, and was discharged on postoperative day number 7. Her post-procedure images are shown, and again, you'll see significant reduction in her septal hypertrophy, no longer any systolic anterior motion of the maybe mild systolic anterior motion of the mitral valve, but with no outflow tract obstruction.
All right, so this is our study. Sherif is our PI for Liberty HCM. This is the first drug that's come out for hypertrophic cardiomyopathy in 50 years. There are numerous sites in the United States. Marty Marin, Barry Marin's son, is the PI. Go to the next slide. And basically it's symptomatic patients. So any patient that's symptomatic with HCM we're interested in, they do not necessarily need to have any sarcomeric mutations or LVOT obstructions. Basically the FDA has accepted the peak MBO2 as a primary efficacy endpoint for approval. And so basically we're currently, I think, the second highest enrolling center in the country. We're going to try and take over that top spot here over the next few weeks. The enrollment should be completed by around June, it's estimated. So if you have any questions, please contact Chris Matera at this number or give one of us a call, and we would be happy to take any other patients with HCM that might be part of the study.
So these are cases that what Dr. Bimaraj was referring to, somebody with HCM doesn't have much in terms of dynamic obstruction that you can offer them, but with a lot of symptoms that can be corroborated on an exercise MVO2. Your tougher cases that you are sort of running out of options to treat, please refer them and we'll be screening them and get back with you.
All right, thanks, everybody.
Thank you. Any questions, comments?
So it's a late sodium channel blocker. It can affect the delayed after depolarizations, and it can also affect the rate of myocardial relaxation. There are data that are being gathered to see whether the drug indeed has these effects.
Okay, great presentation, everyone. So the question I've got is, obviously we discussed the two therapies, either myectomy or septal ablation. Can you elaborate a little bit more on the concern of arrhythmic risk with septal ablation when you're actually creating scar in the myocardium?
Okay. So the likelihood of arrhythmias has been sort of looked as more likely because you are creating a scar, and if you do cardiac MRI, you see the scar after alcohol ablation, but you do not see the scar after surgery. And there are some studies, all of what we have are observational studies that show a higher risk of arrhythmias in some studies with using alcohol ablation to treat these patients. Having said that, there are two studies, one from the Medical University of South Carolina and one from the Mayo Clinic, most recently published, where the arrhythmic risk was very comparable between alcohol septal ablation and surgical myectomy. If one wants to sort of determine a higher likelihood, I would say at the present time the odds may be higher, but it is not dramatically higher that you would be able to sort of identify with the numbers that are now present. So there is a point for ongoing registries to answer this question. But using larger amounts of alcohol, very large scars, very large MIs produced acutely, these would be the typical situations where you can see these events. In the North American registry, there were 5 cases of acute VFib in the setting of MI and 6 cases of non-sustained VTAC, all of which did not end up with problems.
Septal ablation, would that make you more likely to lean towards?
So there is, yes, a point of view of saying that if I have a case going for alcohol ablation and the patient ends up needing a permanent pacemaker after the ablation, it may be reasonable to proceed with an ICD pacemaker implantation as opposed to just a pacemaker implantation.
What's your opinion about the new risk score introduced by European College of Cardiology? There was some controversy apparently in Minneapolis data. It was not predictive. With your database you have you looked at it, see if it'll apply and validate that or discredit it?
We have not looked at the application of the European score to our own database here. I would say that there are published studies from the United States showing that there were cases that when you apply the risk score, you would say the patient should not receive an ICD, and later on these were individuals who had events. So it remained from this side of the Atlantic, the view is it's an individual decision. One risk score is enough. The European approach is sort of appealing in the sense that it's a set of numbers that you acquire, a model, you come up with a value, and according to that you take action. But there is not enough, I believe, at this time to say this is the approach one should take. Also, the European view of alcohol septal ablation is very different. John presented the American guidelines where surgery is 2A and alcohol ablation is 2A only if the person is not a good surgical candidate. The European perspective is different. They are looked as equal from the very get-go.